Welcome to Study Neuro, your neurosurgical teaching series. Today, we'll take you through a structured, step-by-step guide to the clinical examination of congenital hydrocephalus. This approach makes what can initially seem complex much more systematic and clear. Whether you're a student, trainee, or practicing clinician, knowing what to look for will help you recognize raised intracranial pressure, assess neurological function, and detect systemic anomalies that often accompany hydrocephalus. We start with a general assessment, observing growth, posture, and any visible dysmorphic features. The head is examined for size, shape, and symmetry, followed by careful evaluation of the fontanelles for tension or bulging. For patients with shunts, inspection and palpation of the device are essential to check for integrity or signs of malfunction. Eye examination focuses on optic discs, eye movements, and pupillary responses. Neurological assessment evaluates tone, motor, and reflexes, while a systemic exam screens for syndromic features like limb or cardiac anomalies. By following this structured head-to-toe evaluation, you can identify key clinical features, detect raised intracranial pressure early, and perform thorough shunt and neurological assessments. Let's begin with the general assessment and progress through each step so you can confidently examine patients with congenital hydrocephalus. Follow us at youtube.com/studyneuro for more neuroscience and clinical insights. General examination begins with careful observation of the patient's level of alertness, noting whether the child is alert, irritable, or lethargic, as altered consciousness may reflect raised intracranial pressure or systemic illness. The patient is then inspected for dysmorphic features, which may suggest a syndromic etiology of congenital hydrocephalus. The skin and mucous membranes are examined for cyanosis, and the respiratory pattern is assessed for dyspnea, as these findings may indicate an associated congenital cardiac anomaly. In neonates, respiratory distress should also raise concern for aspiration, particularly in the presence of tracheoesophageal abnormalities. Excessive drooling or difficulty handling secretions further support suspicion of tracheoesophageal fistula or esophageal atresia, especially in syndromic presentations such as VACTERL association. The presence of fever should prompt consideration of infection, including systemic infection or shunt-related complications if a device is present. Finally, the patient's posture and spontaneous activity are observed, noting any abnormal posturing or reduced movements, which may indicate underlying neurological dysfunction and help establish a baseline for subsequent neurological assessment. During the general inspection, particular attention should be paid to dysmorphic features, as these may point toward an underlying syndromic cause of congenital hydrocephalus. Facial assessment may reveal hypertelorism, reflecting abnormal craniofacial development, or mid-face hypoplasia, which can contribute to airway and feeding difficulties. The ears should be inspected for low-set or malformed pinnae, as ear anomalies are frequently associated with other congenital malformations. Examination of the eyes may demonstrate ocular anomalies, while inspection of the oral cavity can reveal a cleft lip or palate, or a high-arched palate, both of which have implications for feeding and aspiration risk. Micronaphia should be noted, as it may compromise the airway, particularly in neonates. Finally, observe the neck for shortening or limited mobility, which may suggest associated cervical spine anomalies and has important implications for airway management and positioning. Assessment of vital signs is a critical component of the examination in congenital hydrocephalus. Heart rate should be carefully monitored, as bradycardia may reflect raised intracranial pressure, while tachycardia can suggest infection. The respiratory rate and pattern should be observed closely, since abnormalities may indicate respiratory compromise, aspiration, or brainstem involvement. Blood pressure measurement is essential, as hypertension in the presence of bradycardia raises concern for increased intracranial pressure, while hypotension may suggest sepsis or dehydration. Oxygen saturation should be assessed continuously, particularly in neonates, where desaturation may indicate associated cardiac anomalies, aspiration, or respiratory distress. Finally, weight should be recorded and interpreted in relation to age. Poor weight gain may reflect feeding difficulties. Careful interpretation of vital signs provides important physiological context and helps guide urgency and further management. Head inspection is a key component of the examination in congenital hydrocephalus. Begin by assessing for craniofacial disproportion, where the head appears enlarged relative to the face. The head is often enlarged, reflecting progressive ventricular dilation and expansion of the cranial vault. Look carefully for frontal bossing, which results from chronic elevation of intracranial pressure and remodeling of the frontal bones. The scalp should also be inspected for prominent, dilated veins, a consequence of increased intracranial venous pressure and thinning of the overlying tissues. These visible features provide important clues to the chronicity and severity of hydrocephalus and help distinguish it from other causes of macrocephaly. Head measurement is a fundamental step in the assessment of congenital hydrocephalus. Measure the occipitofrontal circumference, ensuring proper technique, and interpret the value in relation to age and sex-specific growth charts. Particular attention should be paid to the growth trend over time, as a rapidly increasing head circumference is a key indicator of progressive hydrocephalus. Palpation of the anterior fontanelle should then be performed with the child calm and upright. A normal fontanelle is soft and flat. A bulging fontanelle suggests raised intracranial pressure, especially when persistent. A fontanelle that feels tense and non-pulsatile is particularly concerning and may indicate significant intracranial hypertension. In contrast, a widely open fontanelle is often seen in chronic hydrocephalus, reflecting prolonged elevation of intracranial pressure and delayed cranial suture closure. Careful measurement and fontanelle assessment provide essential information about disease severity and progression and are central to clinical decision-making. Assessment of the cranial sutures is an important part of the head examination in congenital hydrocephalus. Sutural diastasis refers to abnormal widening of the cranial sutures beyond normal limits, most commonly affecting the sagittal suture. To assess this, gently place your fingertips along the course of each suture, feeling carefully for separation or abnormal gapping between the skull bones. In a normal infant, sutures are palpable but not widely separated. The presence of sutural diastasis suggests increased intracranial pressure, particularly in young children whose sutures have not yet fused. Identifying sutural widening helps distinguish progressive hydrocephalus from other causes of macrocephaly and provides valuable information about disease severity and chronicity. In any patient with congenital hydrocephalus who has a cerebrospinal fluid shunt in place, a systematic shunt examination is essential. Begin with inspection of the shunt site, carefully examining the scalp and surgical incision. Look for redness, swelling, erythema, or discharge, which may indicate shunt infection, and assess for wound dehiscence or skin ulceration, particularly over areas where the hardware is prominent beneath the thin scalp. Next, assess the shunt valve and reservoir. Identify the valve beneath the scalp and gently palpate the reservoir, noting its position, integrity, mobility, and tenderness. The reservoir should be palpable and mobile under the scalp, but should not be tender, as tenderness raises concern for infection or inflammation. It is also important to be aware of the common sites for proximal catheter insertion, which is where the ventricular catheter enters the brain. The frontal site is the most commonly used, typically just anterior to the coronal suture. Other possible sites include parietal or occipital entry points. Finally, examine the subcutaneous shunt tract along its entire course. Palpate gently to confirm continuity of the tubing and assess for swelling, localized tenderness, disconnection, or signs of fluid collection, which may suggest shunt malfunction, obstruction, or leakage. A careful shunt examination provides critical information about both shunt function and potential complications, and should be performed routinely in all shunt-dependent patients. The eye examination is a crucial part of evaluating a child with congenital hydrocephalus, as it provides important information about intracranial pressure and brainstem function. One of the hallmark signs is the sun-setting sign, where the eyes are deviated downward and the sclera is visible above the iris, indicating pressure on the midbrain and often reflecting increased intracranial pressure. Mechanism: the upward gaze is controlled by the superior rectus and inferior oblique muscles, which are innervated by the ocular motor nerve, cranial nerve 3. The vertical gaze center is located in the dorsal midbrain, specifically in the rostral interstitial nucleus of the medial longitudinal fasciculus. Raised intracranial pressure or dilated ventricles, particularly in the third ventricle, compress the periaqueductal region and dorsal midbrain, disrupting the neural pathways that control upward gaze and producing the downward deviation characteristic of the sunset sign. Next, assess extraocular movements. Look for limited upward gaze and signs of abducens nerve, cranial nerve 6, palsy, which may present as lateral rectus weakness. Observing visual tracking helps assess ocular motility and overall visual function, although intact tracking does not rule out raised intracranial pressure. If feasible, perform fundoscopy. In acute raised intracranial pressure, venous congestion is often observed. Pressure is transmitted to the subarachnoid space surrounding the optic nerve, compressing the central retinal vein as it passes through the optic nerve head. This leads to dilated and tortuous veins and contributes to the disc swelling seen in papilledema. Over time, chronic elevated pressure may result in optic atrophy, with pallor of the optic disc and potential visual compromise. A careful, systematic eye examination, combining observation of eye position, ocular motility, and fundoscopy, provides essential information for both diagnosis and monitoring of disease progression in children with hydrocephalus. The neurological examination is a vital component in evaluating a child with congenital hydrocephalus, providing insight into cortical, brainstem, and spinal function beyond what is assessed in the eyes. Begin with a focused evaluation of the cranial nerves, excluding vision and ocular motility. Pay particular attention to cranial nerve 8 to assess hearing. Raised intracranial pressure can be transmitted to the paralymphatic space of the inner ear via the cochlear aqueduct, which may interfere with cochlear hair cell function and reduce auditory transduction, potentially causing sensoroneural hearing loss. Next, assess muscle tone and posture. Some children, particularly those with associated myelomeningocele, may demonstrate hypotonia, while others exhibit hypertonia or spasticity, reflecting upper motor neuron lesion. Observe spontaneous and purposeful limb movements, noting any asymmetry, weakness, or abnormal patterns that may indicate motor pathway dysfunction. Assessment of reflexes is also essential. Test deep tendon reflexes to evaluate corticospinal tract integrity and examine primitive neonatal reflexes, especially in neonates, such as Moro, grasp, and rooting, which provide information about neurological maturation. When age-appropriate, perform a gait assessment. Look for abnormalities in balance, coordination, or walking pattern, which may reflect motor pathway involvement or musculoskeletal compensation due to spinal lesions. A systematic neurological examination, including cranial nerves, muscle tone, posture, motor function, reflexes, and gait, complements the eye assessment and provides a comprehensive overview of the child's neurological status, guiding further investigation and management. When evaluating infants with hydrocephalus, primitive reflexes offer critical insight into brainstem and cortical spinal tract function. The moral reflex, elicited by a gentle head drop or sudden noise, assesses both brainstem integrity and cortical input, while the rooting and sucking reflexes evaluate early neural development and brainstem function essential for feeding. The Babinski reflex, along with palmar and plantar grasp reflexes, provides information about upper motor neuron integrity and cortical spinal tract development. During the examination, it is important to assess symmetry, strength, and age-appropriate disappearance of these reflexes. Persistence beyond the expected age may indicate delayed CNS maturation, cortical spinal tract dysfunction, or brainstem compromise. Findings should be interpreted in the context of muscle tone, posture, and developmental milestones, and cranial nerve function should be assessed alongside reflexes, particularly moral, rooting, and sucking reflexes, as abnormalities may point to raised intracranial pressure or brainstem compression. A systematic assessment of primitive reflexes integrated with neurological and developmental evaluation provides a comprehensive picture of neuromotor integrity in children with hydrocephalus and helps guide urgency of intervention and further investigations. VACTERL association, also referred to as ACTERL, represents a constellation of congenital anomalies affecting multiple organ systems, including the vertebrae, anus, heart, trachea, esophagus, kidneys, and limbs. Individuals with this condition typically present with at least 3 of these characteristic features. In some cases, VACTERL is associated with hydrocephalus, referred to as VACTERL H, and these cases may follow X-linked or autosomal recessive inheritance patterns, highlighting the importance of genetic evaluation and family counseling. The vertebral and spine examination is an essential part of the systemic evaluation in children with congenital hydrocephalus, particularly because spinal anomalies such as myelomeningocele may coexist and contribute to neurological deficits. Begin with a careful inspection of the spine. Look for abnormal curvatures, including kyphosis or scoliosis, which may indicate underlying structural or neuromuscular abnormalities. Examine the sacral region for subtle skin markers of spinal dysraphism, such as sacral dimples, tufts of hair, skin tags, or hemangiomas, as these may suggest underlying tethered cord or occult spinal lesions. Also, carefully inspect for any visible myelomeningocele or other open spinal defects. Next, proceed with palpation of the spine along the midline. Feel for bony irregularities or gaps, which may indicate congenital vertebral anomalies or segmentation defects. Gentle palpation can also help identify subtle spinal defects not apparent on inspection alone. A systematic vertebral and spine assessment is crucial, as it not only identifies structural abnormalities, but also guides further imaging and neurological evaluation, ensuring that associated lesions contributing to motor, sensory, or gait deficits are not overlooked. The anal examination forms an important part of the systemic assessment in children with congenital or syndromic hydrocephalus, particularly because anal rectal malformations may coexist and influence overall management. Begin with a careful inspection of the perineum. Assess for an absent anal opening, an anteriorly placed anus, or a narrow or stenotic anal opening, all of which suggest underlying anal rectal anomalies. The passage of meconium from the urethra or vagina is highly suggestive of an anal rectal fistula and requires urgent recognition. During this assessment, also observe for abdominal distension, which may indicate distal bowel obstruction or impaired gastrointestinal function. Next, proceed to the abdominal examination, particularly in children with a ventriculoperitoneal shunt, where the abdomen serves as the site of cerebrospinal fluid diversion. Inspect the abdomen for distension, erythema, or localized tenderness, which may signal shunt-related complications, such as infection or malfunction. Gently palpate along the course of the distal peritoneal catheter, assessing for continuity and tenderness. The presence of a localized abdominal mass should raise suspicion of CSF pseudocyst formation, representing abnormal accumulation of cerebrospinal fluid and possible impaired absorption. A thorough anal and abdominal examination is essential for identifying associated congenital anomalies and detecting distal shunt complications, ensuring a comprehensive and safe evaluation of the child with hydrocephalus. The cardiac examination is a crucial component of the systemic evaluation in children with congenital or syndromic hydrocephalus, as congenital heart defects commonly coexist and may influence perioperative and long-term management. Begin with inspection of the child for signs of cyanosis and tachypnea, which may indicate underlying cardiac disease or impaired oxygenation. Next, proceed to palpation. Identify the apex beat, noting its position and character, as displacement may suggest cardiac enlargement. Assess for heaves or thrills, which can indicate increased cardiac workload or turbulent blood flow associated with structural heart lesions. Finally, perform careful auscultation. Listen for cardiac murmurs, with particular attention to features suggestive of a ventricular septal defect, the most commonly associated congenital cardiac anomaly in syndromic conditions. Also, assess for abnormal heart sounds, such as added sounds or altered intensity, which may provide further clues to underlying cardiac pathology. The renal examination is an important component of the systemic evaluation in children with congenital or syndromic hydrocephalus, as genitourinary anomalies frequently coexist, particularly in associations such as VACTERL. Begin with abdominal palpation, assessing for enlarged or absent kidneys, which may suggest renal agenesis, hydronephrosis, or multicystic dysplastic kidney. Palpate for any abdominal masses and inspect the flank regions for swelling, which may indicate underlying renal enlargement or obstruction. In addition, carefully examine the external genitalia. Look for hypospadias or ambiguous genitalia, as these findings may accompany congenital renal and urogenital anomalies. Identification of such abnormalities is clinically significant, as they may warrant further imaging, renal function assessment, and multidisciplinary evaluation. A thorough renal and genitourinary examination is essential for detecting associated anomalies, guiding further investigations such as ultrasonography, and ensuring comprehensive care in children with hydrocephalus. Limb abnormalities are present in approximately 40 to 50% of affected individuals with VACTER, making careful limb assessment an important component of the physical examination. Begin with inspection, noting that the upper limbs are more commonly affected than the lower limbs. Look for congenital anomalies such as polydactyly, syndactyly, hypoplastic thumbs or absent thumbs, which may point toward associated syndromic conditions. Although less frequent, also inspect the lower limbs for deformities such as clubfoot, which may reflect neuromuscular involvement or associated spinal anomalies. Next, assess functional integrity. Evaluate grip strength, comparing both sides for symmetry, and observe for any weakness that may suggest peripheral nerve or central motor pathway involvement. Carefully assess symmetry of limb size and movement, as asymmetry may indicate underlying neurological or musculoskeletal pathology. Finally, examine the range of motion at all major joints, noting any restriction, contractures, or abnormal positioning. A systematic limb examination not only identifies structural anomalies, but also provides insight into neurological function and associated syndromic diagnoses, contributing to a comprehensive evaluation of the child. As we conclude, remember that careful clinical examination remains the cornerstone in evaluating congenital hydrocephalus. Head circumference is the most sensitive and reliable marker, often providing the earliest clue to diagnosis. Sunsetting of the eyes should always raise concern, as it is a red flag sign of increased intracranial pressure. Early recognition and timely intervention are critical because delay can result in preventable neurodevelopmental injury. A thorough head-to-toe examination helps determine the urgency of management and guides further investigations. Importantly, every child with congenital hydrocephalus must be screened for associated anomalies, particularly those seen in the VACTERL association, as these significantly influence overall care and prognosis. Thank you for watching. Share your key takeaway in the comments, and don't forget to like, share, and subscribe to Study Neuro for weekly videos on neuroscience, neurosurgery, and clinical practice. Stay tuned. Neurosurgery made simple.